Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Welcome everyone to another episode of The Pursuit of Health. I'm your host, Rainer Schur, and joining us back on the show is Jared Rhoads. Welcome back, Jared.
Thanks for having me.
So we're having you on again today, Jared, to discuss one of your articles. This one is on cross-subsidizations in hospitals and how they prevent larger reforms. But it's a pretty wonky topic, to be honest. It's very interesting. But I think what would be helpful for our audience is to set a bit of the wider context, which is that hospitals over the years have become more and more scrutinized. And out of that, I think you get a kind of like simplistic narrative where people either say that, oh, they're just sitting on bags of money and have all sorts of regulatory capture, which is not to say that that's untrue. And then the hospitals will respond by saying like, well, we're vulnerable to all these market forces. We need these regulations to protect needed services. And then it just feels like you can't really get out of that. But I think what's actually closer to the truth is that the hospitals rely on some pretty quirky funding mechanisms and frameworks, which then they can use to both capture certain gains in like a distorted market, but also like have some legitimacy to the claim that they're protecting certain needed services. But then what really needs to happen is to question those kind of quirky funding mechanisms. And that's where I think your article is very valuable, where it precisely talks about one of these quirky things, which is cross-subsidization. So let's get started with that, because some people might have heard of it before. It can refer to different things in the health policy space. So what exactly is your article about?
Yeah, to start, well, yeah, you're right. Hospital accounting is a weird world, for sure. You know, famously, you can you can't really ask a hospital manager, a hospital CEO, what exactly does it cost to do this or that? The same way that you can, McDonald's, what does it cost you to make that burger? They can tell you down to like the fraction of the penny what something costs and everything, and hospital accounting just doesn't quite work the same. And there's so what I'm doing in this piece is raising the I guess a little bit of awareness about some what I would call internal cross-subsidization. Now there's a separate cross-subsidization issue that I'll mention because I think it has more. There's just more discussion about it. It pops up more often, and that's the whole question of like, well, do private payers subsidize public payers? Does the high-paying private insurance premiums or payments that hospitals get from those kinds of payers, is that used to offset underpayments from Medicare and Medicaid? Now that's a very interesting discussion. There's all sorts of debates that happen on that, but that's actually not what I'm writing about here. What I'm writing about in this piece about internal cross-subsidization is just the sort of basic kind of observation that hospitals are structured for the most part in a way that some departments are sort of big money makers, and other departments are, I mentioned it I call them chronic money losers, and in the article, and whether that means that they're actually losing money or they're just making razor thin 1% kind of profit. I would put, can both of those in that sort of bucket, as opposed to the other kinds of departments where the profit margins are really high and everything. And so in this paper about this about the internal cross-subsidizations, what I try to do is kind of raise a little bit of awareness that this, first of all, that this happens out there, and if you work in a hospital, maybe this isn't news to you. It probably isn't if you work in medicine, but if you're outside of medicine, just wondering well, why is it that prices are so different from service to service, and also apparently the profitability is so different from service to service. And so part of what I talk about in the article is just sort of like identifying that, right? Orthopedics tends to be a money maker, whereas the emergency department tends to be not. And there are some like understandable reasons for this too. Orthopedics, it's the kind of thing where the orthopedic surgery, it's a service that is high value in terms of the people who are able to pay for it. It's often entails technologies and devices that have that can be marked up, and so you can make profit through those. Through the use of those and the incorporation of those into the services. You can schedule them, and you can have control over when you're doing these services and surgeries and so forth. All of that in contrast to like an ED, where you just sort of have to stay open all the time, 24/7, and be sort of like just kind of waiting for people to come in randomly, and one day might be high volume, next day might be low volume, and so it's just kind of naturally harder to be profitable in that latter case. And so part of the paper is just to sort of raise a little bit of awareness that this is something that's out there. But the other thing that I want to, I think probably maybe the more important and kind of interesting contribution and implication of all of this is that when it comes time to engage in some reforms and the kinds of reforms that we talk about, like having opening up some competition for imaging. Imaging is one of it tends to be a money maker. If a lot of states have certificate of need laws, for example, that make it difficult for a new imaging center to move into town and open up, and a lot of times the justification that the big hospital uses when they show up to that state legislative hearing and they testify against the new imaging center being able to open up, they say, well, we need this profit center because it's whether they admit it openly or not, it's part of their justification, because they sort of have this like almost like a moral high ground that they perceive as, well, we use that profit in other ways, and we need that's what helps our pediatrics stay open. That's what helps our ED stay open, et cetera. And so then then you have departments kind of being used for these extra purposes, right? You're justifying the existence of one department because you're justifying the exclusion of competition because you're saying, well, we use that for other purposes in our hospital.
So I definitely want to get more into later on how cross-subsidization makes reforms more difficult, as you've pointed out. But just to round out the definition of it, it's not merely the fact that hospitals have some profitable services and some unprofitable ones, is that they use the profitable ones to kind of keep the unprofitable ones afloat. And so one question that I had, and you addressed this in your article, which is really interesting, is someone might think that, well, I mean, doesn't some kind of cross-subsidization exist in other industries, like the airlines paying for more expensive seats with other seats, or in the train industry with freight paying for passenger trains? What's your response to that kind of argument? How is cross-subsidization different in hospitals?
Yeah, no, that's a good point. There's differences between like to like bring in some like business lingo, right? There's like market segmentation versus cross-subsidization. In something like airlines, they will have they make good money on the first class ticket, and that kind of helps keep costs prices low for the economy class, right? And, I mean, but they're making money everywhere, right? They're not actually. It's not like they're losing money on economy class and then using business class to make the money and cover that and still, like, turn a profit and stay in business. What they're doing is what it would be market segmentation, is sort of, this type of traveler can afford to pay more and is open to that and everything, and they've just they've found ways to serve different people with different needs and different abilities to pay, et cetera. And it's and the both kinds of products there contribute to the bottom line, and they keep that business afloat. In cases where it's like more of like a cross-subsidization, and there are some like historical cases. So like I mentioned, like the railroads, for instance. There are times in history where the freight and the passenger services on a railroad are sometimes in this situation of one subsidizing the other. The passenger service might be harder to turn a profit on, but the freight is doing really well. But what tends to, historians, I'm not an economic historian, but from what I've read in the economic history literature, those kinds of arrangements tend to be unstable over time. And if for a brief moment, if it's a transitional part of the of history or something like that, it helps develop other things, but it doesn't tend to persist. And whereas in hospital, we have, I think, seen for a very long time this kind of persistent cross-subsidization. I also use sort of the example like Walmart. Like, I think that's a good and handy thing to imagine. Like, you imagine a Walmart store. It's probably not the case, and in fact, I know it's not the case that one one department is making absolute bank, and the other one they're just losing money day in and day out on it. Now I'm sure there's some differential maybe in department profitability if you're looking at like sporting goods versus home goods or personal care and beauty or something like that. And I'm sure there's differences, and it probably fluctuates and so on and so forth. But in there, it's sort of there's other reasons there can be some cyclicality between and seasonality between like different departments, but the important thing there with that distinction, like, I'm not sure I've ever heard of like a Walmart going to the legislature to like purposely keep out a new sporting goods store from opening up. Let's say that's the department where they're making a lot of, like a high profit margin. I don't even know if that particular example is true, the sporting goods being a high one. But if you pick one of their departments that maybe does well historically, they don't use that in a political way to keep out competitors. By saying, oh well, we need to keep out the sporting goods competitor because that subsidizes our garden center or something like that, and then getting politically involved in that exact way. But you do, unfortunately, I'm afraid, see that with hospitals, like we were saying, the imaging center that does well, keeping out competitors through certificate of need laws. In order, and partially justified by the need to, again, keep the ED open or pediatrics or psychiatry or something like that.
I think what you said before was also very helpful, to point out that these kinds of internal cross-subsidization that you see in other industries from a historical perspective are just inherently unstable. And if that's the case, that provides a whole different light to understanding why these hospitals struggle sustaining these services. People might think that, it's not enough funding from the government, or like, they're just being greedy, they want to cut like these unprofitable services. But if there's something inherently unstable about them, it kind of just explains why they're always kind of struggling to like balance this impossible thing that's not stable. But another thing that I think is interesting in your article to point out is that uh, this kind of cross subsidization in hospitals inherently distorts prices. And you might think that that doesn't matter. These services are needed, but prices are important. So can you explain a little bit to the audience how not only cross subsidization distorts prices, but how that's actually harmful for patients?
Yeah, yeah. I mean, prices are really important, and when the services that you're offering, you're not pricing them in a way that they really reflect the actual cost of providing them. You're sort of, I don't know. You're gouging, to use a phrase that I would probably put in scare quotes, but you're really like raising the price really high on this area over here, this service, because you have limited competition, which you've kept out through political means. You're doing that on one hand, but then you're keeping another service price really like artificially low, almost, right? That's the subsidization part of it. It's not. I mean, maybe you think you're helping, but you're kind of not. Because you're suppressing valuable information. Any Austrian economics people out there, fans of Mises or Hayek or something, they know that the importance of the information that goes along with prices. Prices are like massive signals to other suppliers to move in. If a particular service is doing really well, profit margin wise, somebody that's something that attracts new suppliers, which then brings the profit margin down. It still keeps it positive, but keeps the margin lower, which is better for consumers, right? So you have prices falling, which is good for consumers, and so but without that information, because instead of using like real prices, we're kind of using fake or hidden prices. A lot of these cross subsidies are hidden. I mean, if it's a private organization, you can't find out what exactly, you can't pull up the books of a private organization and figure out exactly what it is. So you don't really have a good sense of like, where the margins are like artificially high or artificially low. And then so that is a kind of a suppressor of entrepreneurial activity, I would say, which is unfortunate.
Right. So there's ways in which cross subsidization distorts prices as such, but there's also all sorts of ways in which those distortions are compounded by the whole kind of regulatory apparatus in which cross subsidization occurs, such as with a kind of de facto price setting from CMS. Could you explain how that contributes to cross subsidization?
Yeah, yeah. So the fact that so many hospitals kind of anchor their pricing and based on reimbursement rates that Medicare is set up with the prospective payment system. These are not real prices, which is it always bears. We say it a lot at Center for Modern Health, and tweet it out a lot, and it makes a lot of appearances in our articles. It's something to always remind people of that when the government or arranges a committee and they sit in a room and they kind of take a guess at what something should be reimbursed at based on like, well, how many hours of work does it require and that sort of thing, and they come up with their relative value system. It might be their best attempt, but it's not a real price because it wasn't arrived at in a market way. It wasn't arrived at through a process where you have people bidding buyers bidding it, which moves it one way, and then on the other hand, you have suppliers competing to offer it at lower prices in order to have supply and demand meet. And so again, I'd even stop myself from calling it a price. The reimbursement rate that you get from a government committee is somebody's guess, but it's not a real price. It's not. It doesn't contain that market information. It doesn't include all the knowledge that. That all of the buyers have about their situation, as well as all the knowledge, all the decentralized knowledge that the multiple suppliers have about their situation. Like they know whether they can offer something at a particular price or not, right? If they do, then they offer it at that price, and it's based on a realization and a whole bunch of calculations that they've done that, oh yeah, based on our prices and our own costs, et cetera. That all of that information that they know that the government committee can't possibly know. That's why reimbursement rates are so different than real market prices.
Yeah, I find that very helpful because it shows that, or it at least leads to reason to think that it's not simply hospitals wanting to insist on this quirky way of funding unprofitable services. They operate in a very distorted system as it is, and so on the one hand we can blame them for like stopping certain reforms, but on the other hand, like if you're in their position, can you really blame them? And can you really expect them to take on the entire system? How do you think about that? Like where the blame really lies here?
Yeah, yeah, no, I agree. I mean, this isn't the piece that I wrote here, which is going to be coming out in Law and Liberty pretty soon. It's not intended to be like a real blaming kind of piece, and look how awful this group or that group is or anything like that. It's really just trying to kind of again sort of raise awareness about that this is going on, make the connection. That's the first thing. Secondly, to make the connection that it can hinder reform because it's used as that justification in the political arena, unfortunately. And then I guess third, I hint at a few kind of directional solutions or things we might look at, but this isn't. And that's to indicate that there are some things that we can probably do, but I think there's more thinking to be happening here on this issue, probably more research. There's so like there are some things that we could look at. We could look at again like taking away the whole con law component of it is one way to influence this issue. Now, I don't think that like solves the entire thing, overnight or anything, but that's like, kind of one way to sort of address and chip away at this weird situation. If we have con law reform, then what that does is that sort of takes away that artificially high profit area for a hospital, which honestly gives them kind of a justification and like gives them cover, what maybe they need, kind of in terms of like a public affairs kind of sense, to be able to say, hey folks, we need to raise our prices in obstetrics, or we need to raise our prices in the ED services because we're making less over in these other services where we had protections that we didn't deserve, and those went away, and so we need to like kind of rebalance things and make all of our services more accurately reflect what they really cost, and that's it's kind of it's a change that could trickle down from a change in con law. So that's sort of one thing to do. Another thing that isn't exactly a political reform or a policy reform, but I mean just getting the kind of again awareness about this out there could cause certain institutions and hospitals to just kind of almost like voluntarily kind of engage in a little bit clearer accounting and greater transparency around this. They could give a better justification of why something costs the way the amount that it does, if they can show that hey, it really is kind of inefficient and hard to keep an emergency department open 24/7, and with all of these amazing technologies at the ready just in case we need them, right? And there could be devices and pieces of specialized equipment that only get used, once a month or something like that, because it's a rare situation where it comes in. And you can, I'd like to think that you could make that case kind of rationally to people, and and that you wouldn't exactly get the just an instant pushback. So there's it's kind of like a call for possible voluntary greater honesty and transparency in that. So I think I think there are some things policy wise that could be done, and also just sort of like culture of medicine kind of changes that might be able to come about as
Yeah,
a result of this.
yeah, I think the most valuable part of your article aren't like the specific policy recommendations, which are of course very important. It's challenging the narratives that are out there, and for the hospitals that abuse the cross-subsidization narrative to uh, prop up unprofitable services with highly profitable ones in a kind of like absurd and kind of unfair way, which is of course hard to say, because how can you determine fairness in a market that isn't free to begin with? But you can point to certain actors in this space where like they're really just abusing this argument, and this uh, counter argument that you're providing is a way to kind of like disarm them from using that shield unfairly. But I think it's not just that, because then it can also help point out that certain hospitals that are more honest, you can show them that they've kind of trapped themselves in this situation where they're kind of dependent on this weird, quirky funding mechanism, and it kind of prevents them from getting better. So it's kind of a double injustice that it's being used to both prevent new and more competition outside of the hospital, but also prevents the hospital from changing and getting better.
Yeah, no, I agree. And I kind of, close out the piece with really just sort of on a note of saying, gee, let's have a little bit of more respect for prices and profits and losses. Like if you know that you're highly profitable in one area, that can guide you, that can tell you certain things. If you've gotten it, but not by some sort of protectionist scheme, but if you're actually kind of earning that tells you one thing. If you're if you're making a loss, if you're just barely scraping by in another area, that can be a signal to rethinking that. Businesses, when you do have scenarios where like a department or some part of your business, again, to like bring it back to like regular industry, other industries, and other the Walmart example and so forth. If something's going wrong in an industry, and you're not able to really like make that viable, you've got to rethink it. Maybe prices, because you have been cross-subsidized, or cross-subsidizing it, you need to raise the prices on that. Or maybe there's just like efficiency things that you need to adopt, or you need to restructure how it operates. Um, you know, Businesses and the Walmarts of the world, they're constantly trying to fix and reform and improve the way that various departments work in order to keep them all viable, and not have any one of them be a sort of a drag on the whole enterprise. So yeah, I'd like to get this get this word out there, get people thinking about this issue alongside. It's not unrelated to the other type of cross-subsidization issue. There are connections, definitely, but it's definitely a distinct kind of phenomenon. And yeah, I think people conversing about it, thinking about it and taking some policy changes where we can identify some policy levers that would help would be a good thing. And there's more work, I think, to be done on this sort of general topic. And I'm looking forward to being part of that.
And definitely the previous point you made about how real prices would do so much to fix a lot of healthcare is, I think, a point that bears repeating over and over again. And we'll include a description and link to the article in this episode, and I think that's a good place to end. We'll leave it at that, and I'd like to thank our audience, and until next time.
Thank you very much.
To stay up to date, subscribe to our show from whatever podcast platform you're listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.